From Redfield Medical Direction, I'm Lynn Nguyen, Associate Medical Director, and this is our EMS Podcast, your link between protocols and practice.
So, Dr. Nguyen, after discussing the high-risk refusal podcast last time, it got me thinking about some tricky scenarios that we kind of run into quite frequently, to be honest. One is alcohol intoxication and medical decision-making capacity. This is where a lot of EMS providers struggle because just being drunk doesn't automatically mean someone can't refuse care.
You're right. Even if you ask like 5 different doctors, you might get 5 different answers. Some people think that if a patient has any alcohol on board, they have to be transported. Others assume that if the patient can talk, they're perfectly fine to refuse. And I think the truth is, it's just not that simple.
Exactly. The key takeaway from the ACEP position statement paper is that intoxication exists on a spectrum. Just because a patient has alcohol in their system doesn't mean they automatically lack capacity. Some people can be legally intoxicated but still meet the 4 elements of decision-making capacity. Understanding, can they grasp what's happening to them? Appreciation, do they understand the risk of refusing? Reasoning, are they making a logical decision or is their thinking impaired? Lastly, expression of choice, can they clearly and consistently refuse care?
And this is where EMS has to be really careful because, let's be real, alcohol affects different people in different ways. A chronic alcoholic might blow a .25 and still hold a perfectly normal conversation without any slurred speech, while a first-time drinker at .15 might be absolutely incoherent.
That's completely true. That's why these blanket policies don't work. You need to assess function, not just alcohol levels. A few red flags that should make you question capacity in an intoxicated patient are slurred speech or incoherent thoughts, can't answer basic questions about what happened, signs of head trauma, hypoxia, or shock, and can they stay awake or keep their balance while you're talking with them. If any of these signs are present, their capacity is compromised, and they should not be allowed to refuse transport.
And let's talk about documentation. If you're dealing with the intoxicated patient and you're trying to document their refusal, your chart really needs to show what the patient said, even in quotes, and how they responded to your questions. Whether they were able to hold the conversation with you in a logical fashion. Make sure in your physical exam that you document any signs of head injury, trauma, or any medical concerns, maybe like a low blood sugar. And that you assess all 4 elements of capacity that we touched upon in our last podcast. Because if the patient is found unconscious later, you will be asked why you left them.
And if you're not sure, always call med control. If you've ever had the slightest doubt about their ability to make an informed decision, you should err on the side of transport. Courts will almost always side with EMS if you acted in the patient's best interest and in good faith.
So bottom line, don't assume all drunk patients lack capacity, but also don't assume that they have capacity just because they say I'm fine. You as an EMS clinician need to make your own clinical assessment.
Absolutely. And remember, if they're too drunk to drive, they're probably too drunk to refuse EMS care.
That's all we have for this episode. This podcast was written by Dr. Redfield and produced by me, Lynn Nguyen. Our theme music is from Infraction. As always, if you have any questions, don't hesitate to reach out. See you next time.